Good afternoon, and thanks for the opportunity to be here. So what I've got in terms of slides is what I hope is a very pragmatic, down-to-earth thing, not terribly esoteric and high power, but it does require you guys to do some of the work. So I was going to start with a little bit of revision, if you like, about the biology of bone. When I went to medical school, we didn't even know about bone biology. I think we thought that bone was about as dynamic as a concrete block. But it's not. There are actually cells in bone. There are cells that are making bone and taking away bone. And that's why our bones get weaker as we get older, because the balance of bone manufacture and bone resorption gets out of kilter as we get older and our bones get thinner. And when we move into the therapeutics of bone disease, then we're basically manipulating the behavior of the bone forming cells and the bone resorbing cells. So it's important to look those cells in the eye so you've got an idea of what you're doing when you start someone on a bisphosphonate or Teriparatide or whatever. And then just to talk about the drugs that we've got available in the New Zealand market, and then go through some fairly common scenarios. It's not very difficult to know who to treat these days. There are ways of calculating fracture risk and you get a yes/no answer. And PHARMAC makes it very straightforward for us by not licensing or reimbursing very many products, so we don't have a vast array of different things to wrestle with. So the idea of who you start on treatment is pretty straightforward. What gets rather more tricky, and the clinical trials are not particularly helpful, is what do you do after 5 years or 10 years or 15 years? And so I think that's where most of the challenges that we all face in the therapeutics of osteoporosis lie at the present time. So that's roughly what I'm going to talk about. So let's set off on the journey and see where it leads. So to start off by talking about the biology of bone, and this may be familiar to some of you, but probably not to all, so I'll go through it. So this is the bone remodeling cycle. So if you drill down into our skeletons, most of our bone looks like this. So you've got plates of bone and you've got sleepy cells sitting on the surface not really doing very much, and that's what the vast majority of our bone surface looks like. But in the course of the next 24 hours, at about 20,000 different sites dotted across your skeletal surface, a group of these lining cells will peel off, exposing the bone underneath, and that acts as a chemoattractant to pre-osteoclast. So these are the cells that can develop into bone resorbing cells, and they sit in the marrow space overlying the bone. So when you expose some mineralized bone, you recruit osteoclasts to that surface, and the osteoclasts recruited in the next 24 hours will spend the next week drilling 20,000 little holes in the surface of your skeleton. So you'll wake up next Friday morning with 20,000 new holes, and at the end of that time those osteoclasts turn up their toes and die, and that potentially leaves you with a problem. But the osteoblasts are sitting in, or pre-osteoblasts are sitting in the marrow space waiting to rescue you, and they colonize those 20,000 little holes, and they will spend the next 3 or 4 months making nice new shiny type 1 collagen plugs that fill the 20,000 holes. So by the time we get to about next February or March, you will have nice little collagen plugs filling in the spaces that have been created in the next week. And then as long as the calcium and phosphate levels in your circulation are what they should be, those plugs will mineralize, and so by about next March or April you're right back to where you started. So that sounds like a monumental waste of time. But it's not really, because what it does is it means that we actually rebuild our skeleton roughly every 10 years. And the areas of our skeleton that we load hardest tend to turn over more quickly, and those that have less stress and strain placed upon them more slowly. But that is how we can get through a normal reproductive life, if you like, with a relatively light skeleton. Even though we have falls and bad things happen to us, we don't accumulate that damage when we wind up at the bottom of a rugby scrum or something similar. That area of bone gets remodeled and gets repaired even if an actual fracture hasn't occurred. So that's what happens when you're 25 or 35 or 45. When you get 55, 65 and 75, it gets a little bit pear-shaped. So in the absence of sex hormones, and I mean obviously falls in sex hormones are much more dramatic in women than they are in men, but even though a lot of men may be in denial, there is a male menopause. Testosterone levels fall less dramatically and it's somewhat later, but probably that's a key part for male loss of bone density as well. But in the absence of normal levels of sex hormones or premenopausal levels of sex hormones, there are more of these remodeling sites developing every day. And the osteoclast, the bone resorbing cells, tend to dig deeper holes. And sometimes they dig, remembering this is a bone plate, your bones are not solid. So sometimes the bone resorbing cells actually dig a hole right through the bone plate. Now that's a bit of a disaster when that happens, because then there isn't any surface for the bone forming cells to come and settle down on. And so the process gets arrested at this stage with a hole punched in your bony plate. And so what was meant to be a process of skeletal renewal becomes a process of skeletal destruction. If the osteoclasts just dig a deeper hole but not quite deep enough to punch through, then you still get bone formation taking place, but the bone forming cells in our 60s and 70s are not as vigorous as our bone resorbing cells, and so the process of filling in the hole gets arrested roughly here, so that you have a gradual thinning of your bone plates taking place. So let me just show you a couple of slides that demonstrate that I'm not making this all up. So this is a normal piece of bone taken from a healthy young volunteer, just from the iliac crest, and this is their trabecular bone. And you can see when I talk about bone plates that these really are bone plates. You can also see that they're pretty robust plates. They're not thin little slithers of bone. They're big solid chunks of bone, and the bone marrow sits in the spaces in between. And you can imagine that you might jump up and down on something like that for 70 years and get away with it. Looking at the bone surface, it bears out what I've just said, that most of the bone surface is very smooth, so that's actually covered by lining cells, but there isn't major excavation of bone taking place. But we do have one of the remodeling sites I've talked about here, and that looks as though it's probably still got osteoclast in it at the time that this biopsy was taken. And up here we can see the process a few months further on, where there's just a shallow, rather smooth indentation, and probably, and this is inferential, that used to look like this, but it's been filled up with osteoblasts, and they've almost completed their job of replacing the bone. So that's what it looks like when you're 25. If you take a biopsy in exactly the same way, and the magnification and everything else is the same, but this is from someone in their 70s who's already had multiple osteoporotic fractures, you can see that there's really not much correspondence. Now, this is all bone plates. We have one bone plate here, but somewhat thinner than what we saw on the previous slide. Up here we have what was once a bone plate, but osteoclasts have punched a hole right through the centre of it, and so it's converted the structure into struts rather than plates. And obviously something like that is not as robust as what we were seeing on the previous slide. We've got more struts here, and on the surface of that strut is a hollow. What do you think that depression's caused by? Yeah, so it's bone resorbing cells. So this is actually, when these sorts of pictures became available in the 1980s, this was quite illuminating really, because we'd sort of thought, well, there's a lot of bone loss and it takes place in your 50s and then it slows down and, you know, what the hell. But actually what this is telling us is when you've had multiple fractures and you are in your 70s or 80s, the osteoclasts are still hammering away at the bits of bone that are holding you up. And you obviously, when your skeleton is as fragile as this at a microscopic level, you don't need to lose much bone if you're losing it in critical places to actually have a substantial decrease in skeletal strength. And so I think the likelihood is that if this biopsy had been done a day or two later, that group of osteoclasts probably would have punched through that strut. And that doesn't decrease the local bone density very much, but it completely removes any biomechanical value from that section of the skeleton. And we can see down here the next stage in this process, so osteoclasts have punched through this strut, and the remaining bits of bone, because there's now no load on them, are just gradually retreating away, because you only maintain your bone if it's actually got some load bearing down upon it. And the final product of that sort of process is what we see in the bottom right-hand corner, which is no bone at all. So when these pictures became available about 30 years ago, the first message that people took from them was that we need to go for prevention rather than cure, because this is not just a thinning of your bones, this is a major damage to the microarchitecture of bone. And even if we get really clever and have drugs that will make bone cells, you know, beef up and make more bone, you're not going to be able to reconstruct the microarchitecture. And so I think in that period of time, quite appropriately, and that message is still very important, is that we should do what we can to slow down the activity of the bone resorbing cells, and actually most of the drugs we use in osteoporosis do exactly that. And we should try and preserve the skeleton that we have and preserve its structure. When the first big osteoporosis trials that were aimed at fracture prevention took place in the 1990s, the first of them got stopped early because of a significant decrease in numbers of fractures in the treated group after only about 2 years or so. And that was quite a surprise because those people had only gained a few percent in their bone density, but they were already having half as many fractures as the people in the placebo group, and that was not what was expected. But actually this picture also explains that, because if we can stop these fragile bits of bone being sawed through by the osteoclast, then we don't have to push your bone density back up to where it was when you were 25 in order to substantially reduce your risk of fracture in comparison with people who are untreated. So the second take-home message from this picture, so the first is prevention's better than cure. The second is it's never too late to intervene. And actually that message is very much in common with cardiovascular disease, where again, in my practicing lifetime, we've gone from the idea of saying, well, you know, he's had 2 heart attacks already, forget it, to actually realizing that it's the people at highest risk who have had the most events who actually get the greatest absolute benefit from intervention, and that's very much the case in osteoporosis as well. Okay, so that's enough biology. Let's move over with that background into the therapeutics. And I think the general sort of therapeutic paradigm is pretty simple. These days we don't really talk about diagnosing osteoporosis. There is still a WHO sanctioned definition of osteoporosis, which is purely in terms of bone density. But actually, osteoporosis is not a disease. It's not something you either have or don't have. We all turned it into a disease because otherwise people like PHARMAC won't fund the drugs. But it is a process. And as I've implied, anyone who lives past the age of 50 to 60 is embarked on that process and is losing bone. And whether you have fractures depends on a variety of things, but it depends on how strong your bones were before you embarked on the process of bone loss, how long you are embarked on that process. So obviously if you die of something else at the age of 60, your chance of having a fracture is much less than if you live to the age of 95. And also how often you fall over. So there's a whole combination of things that determine whether you're going to have fractures. So we now tend to, rather than talking about bone, whether you have osteoporosis or not, we assess fracture risk, and I'll talk in a minute or two about how we do that. Whether or not your risk is high, it's sensible to correct reversible risk factors, and again with strong parallels here with cardiovascular disease. And then if your risk justifies intervention, then provide an intervention. And as I said a few minutes ago, one of the biggest challenges is follow-up. We've got clinical trials that run for 3 years. We know that if you take someone with these characteristics, put them on this treatment, 3 years later their risk of fractures is reduced by 40%. But then what do you do for the rest of their life? Because the clinical trials, in terms of having placebo controls, tend to run out at 3 years, and so we have to wing it somewhat for the rest of that person's life, because their risk doesn't go away. This is not like treating pneumonia, where after you've had your 10 days of antibiotics, it's all back to square one. This is a process which is going, and a risk which is going to remain with you long term. Okay, so there are a number of different ways of assessing fracture risk, and people keep on publishing more. This is probably the most widely used one. That doesn't mean it's necessarily the best, but it's called FRAX. It is sort of endorsed by the WHO. There's been a little bit of debate from the WHO end about the level of its endorsement recently. But if you want to get to this, you just type FRAX into Google and it will take you to the University of Sheffield website where this sits. You can dial up a particular country. We actually use the UK version of FRAX because it actually gives more accurate fracture prediction in white New Zealanders than does the so-called New Zealand version of FRAX. So you fill in what are a collection of widely recognised risk factors. So age, sex, weight. Being skinny increases fracture risk. If you've had fractures before, you're more likely to have them again. If your parents have had fractures, particularly at a young age, you're more likely to. If you smoke, you're more likely to fracture. If you take glucocorticoids, if you've got nasty inflammatory illnesses, and if you drink too much alcohol, all of those things increase your risk of fracturing. If bone density is known, it can be filled in, but you don't actually have to put bone density in. You can press the calculate button without a bone density and it will give you an answer. And so some docs use this without bone density to determine whether maybe they should be sending their patient off to have a bone density measure, because if you're getting a very low fracture risk without bone density, measuring bone density is probably not going to make an appreciable difference. Whereas if you're in that borderline area, should I intervene or not, then that becomes quite influential. So you click on the calculate button and it tells you what your 10-year risk of having a major osteoporotic fracture is, or of having a hip fracture. Now, I don't think those numbers are particularly useful to share with patients because I think they're prone to misinterpretation. If you've got a 10-year hip fracture risk of 3%, some people will say, well, that's only 0.3% per year, so that actually means your risk of not having a hip fracture in the next year is 99.7%, so don't worry about it. But it's not quite as reassuring as that, because obviously all of these different fractures run together. For the calculation of major osteoporotic fractures, they only include about half of the total number of fractures that occur because they're much easier to ascertain from databases. So actually this particular individual probably has something like a 40% risk of having a fracture of some sort over the next 10 years. But the value of FRAX and the other calculators is that it allows you to synthesize the bone density and the other clinical fracture risk and come up with a single number which you can then benchmark against a nominal sort of threshold for intervening. And usually the thresholds for intervention are based on pharmacoeconomic analyses, and the number that people came up with about a decade ago in North America was that when your hip fracture risk for 10 years reaches 3%, then it's cost effective to intervene. Now that was when a standard therapy for osteoporosis costs $300 a year. Now we have generic bisphosphonates, which cost as little as $30 or $40 a year. And so the decision to intervene or not really comes down more to a balancing of benefits and risks, because the cost part of the equation has become almost insignificant. And I think PHARMAC has recognised that. We now have generic risedronate available with no special authority conditions, whereas the more expensive agents do have special authority conditions attached to them. Now, it's important to remember that FRAX is not the only way of assessing fracture risk, and the other one which we use quite commonly clinically is Garvin. And it's interesting, these guys all basically did the same thing. They got big databases, observational databases, where there was baseline measurements of risk factors, follow up over a decade or so to count the number of fractures, and then you give them to your statistician, pushes them into a computer, and it spews you out an algorithm for how you predict fracture risk. Now, anyone who's done that will realize that if you do that a dozen times, you may get a dozen different combinations of factors. And so the Garvin one came out with a much simpler set. So age is still important. Fractures since the age of 50 is still important. But here, they're a bit more sophisticated. They don't just have fracture as a yes-no, they count the number of fractures. And that's very important, because if you've had 3 fractures since you were 50, you are at a much, much higher risk than if you've only had 1. And they also count falls. And the FRAX people acknowledge that falls are really important because most fractures follow falls, but their databases did not consistently record falls, so they aren't able to deal with that. But it's very clear from the Garvin calculator that if you've had multiple falls in the last 12 months, your risk of fracture goes way, way up. So, and then you can put bone density in as well. So sometimes Garvin gives us the same answer as FRAX, but other times it doesn't, and I'll talk a bit more about that in a few minutes. Okay, so we've done the calculations, we've decided that someone's got a fracture risk that warrants intervention or not, and what have we got to offer them? So this is a recent sort of network meta-analysis of different therapies that are available and showing their efficacy on non-vertebral fractures, and I've put boxes around the agents that are available in New Zealand. So we've sort of more or less abandoned using calcium and vitamin D, except in specific circumstances, which I'll come back to at the end, because they don't prevent fractures when you assess them in most clinical trials. Alendronate or Fosamax is still under special authority. It reduces non-vertebral fractures by about 30%. Generic risedronate is much more freely available, roughly the same anti-fracture efficacy. Zoledronate is available as an intravenous infusion that you give maybe every 18 or 24 months. The registration documents actually talk about administering it annually, but that's probably unnecessary. And again, that's comparable in its efficacy. Raloxifene, for political reasons, is reimbursed, but it doesn't actually prevent non-vertebral fractures. It does prevent vertebral fractures, but they're a much more minor issue, so effectively raloxifene is not used in most countries. from the 1st of July this year, denosumab, which is it's a potent monoclonal antibody that targets the protein that switches on osteoclast development. So when you take denosumab, which is given as a 6-monthly subcutaneous injection, it effectively wipes out the development of all your bone resorbing cells. It's a very potent anti-resorptive. It produces big increases in bone density, and it produces much the same decrease in fractures as the much cheaper bisphosphonates. And then we have teriparatide, which is about $5,000 a year in this country. That's given by daily subcutaneous injections, and it works completely differently from the other agents we're talking about here. It targets mainly the bone forming cells, and it switches them on. It also switches on bone resorbing cells, but generally to a lesser extent. So whereas everything above that line is damping down the cellular activity in bone, teriparatide increases the cellular activity in bone. It produces the biggest increases in bone density. Maybe it produces the biggest decrease in fractures, but you can see the confidence intervals there all overlap. And I think quite appropriately, in view of its cost and the issues about needing daily subcutaneous injections, that's reimbursed in this country very much as a second-line agent, though actually the clinical trials that have assessed it have generally used it as a first-line agent. So that's what we've got to use. So let's move on and talk about a few patient scenarios. So, and these are all somewhat similar to one another, and they're totally artificial, so I'm not upsetting anyone's confidentiality, but they've been sort of crafted, if you like, to bring out one or two practical issues. 58-year-old woman, history of 2 forearm fractures. She had 2 falls in the last year, hasn't had any osteoporosis treatment to date. Her bone density is not actually in the osteoporosis range. So does everyone know about T-scores, or should I quickly talk about T-scores? Sure. Oh, okay. So the difficulty we have is that every different manufacturer measures bone density differently in slightly different places. And so, you know, a measurement in your spine on one machine of 0.8 could be something completely different at the hip on another machine. And so rather than all of us having to keep all of these numbers in our heads, the way bone densities are usually expressed is in relation to the young normal range at that site on that machine. So a T-score of minus 1.8 means that the bone density is 1.8 standard deviations below the average value in the young normal population on that machine at that site. So you can intermingle different sites and different machines without having to be fussed about it. The WHO has arbitrarily defined osteoporosis as being 2.5 bone density 2.5 standard deviations or more below the young normal mean. So this is a pretty standard bone density, probably for someone in their late 60s or early 70s. It's a bit lower than you'd expect in the average 58-year-old, but it doesn't constitute osteoporosis. So if you calculate their hip fracture risk on FRAX, it's 1.9%. Major osteoporotic fracture risk is 11%. And I talked about 3% being the sort of notional threshold for intervention at the hip, and it's 15 to 20% that we use as our notional threshold for intervention based on major osteoporotic fractures. So if you were a GP seeing this person, what would you recommend? Yes, well, I think that's really, really important. And people like me who are focused on bones tend to get worried about bone density and all that kind of stuff. But focusing on falls is critically important, and it's not an either or, it's a both. And so I think particularly a person of this age who's having 2 falls in a year, I mean, it does occur, but you really want to look at that. And that's a whole science in itself. So, you know, some people are having falls as their presenting sign of Parkinson's disease or some other neurological problem. Maybe she has too many glasses of wine a day. But there are a whole lot of reasons why people have falls, but particularly in someone this age, you want to be very carefully looking at that. When you get into the frail elderly, then falls are not that uncommon, but they're even more damaging in that age group. And then you want to be thinking very carefully, working with your geriatrician colleagues and OT colleagues, of ways of reducing falls. And the things that reduce falls are stopping sleeping tablets, though usually you get beaten up on and people want to start them again. But getting up in the middle of the night to go to the loo when you're doped to the eyeballs with whatever doesn't augur well in terms of you having a successful return journey to bed. getting your glasses sorted out, and so these multi-focus glasses are a plus and a minus, because if you're trying to go downstairs and actually the bottom part of your multi-focus glasses is actually designed so you can read the newspaper, so you can't actually see the edges of the stairs, so you have to encourage people to hang on to handrails or have multiple pairs of glasses that they change around, but then they do actually have to change them around because, again, if you get up and go to the loo with your reading glasses on, that's not necessarily a good way to set out on that expedition. So glasses, medicines, there's a couple of other things. But anyway, falls is a big issue on its own, and many of you probably know more about that than I do. Okay. Other comments on this? So we're going to look into the falls. We're going to provide some interventions there maybe. What else are we going to do? Well, I'm going to come to that towards the end of my talk, but actually in a 58-year-old, if she is leading an active life, then it's almost certain that giving an extra vitamin D will make no difference. Now, if she was never going outside, and there would have to be a really good reason for that, but if someone is severely frail and unable to venture outside so they don't get sunshine on their skin, or if she was from Ethiopia and was veiled, then yes, she could well have profound vitamin D deficiency, and intervening with vitamin D would be sensible. But in your average light-skinned New Zealander leading an averagely active life, vitamin D supplementations really don't make any difference. Okay, well actually this was nicely set up by my previous slide talking about Garvin, because what FRAX doesn't do is take cognizance of multiple fractures nor of the falls. And actually, if you do a Garvin calculation on this lady, you find that a 10-year hip fracture risk is 17%, way over the threshold for intervening. So I just sort of mention this because we often get so locked into FRAX that we overlook the omissions of FRAX. And so I quite often, in people who are borderline or people who've got issues with multiple fractures and falls, do a quick Garvin as well. And of course this is way above the PHARMAC threshold of 3% for reimbursement, and so this person can very appropriately start on treatment.